Vishwa, good morning, good evening. You're in Bali right now, aren't you?
Good evening for me. Good morning for you.
That's right. It's good to see you.
Nice to see you.
Last time we were together, we were up in New York City just a couple of weeks ago. Pretty exciting times for SS Innovations.
Yeah, that was sort of our, showing the system after the Society of Robotic Surgery meeting. We just wanted to showcase to the people who weren't able to see it physically, and I think we had a pretty good, turnout in our office in New York.
Yeah, fantastic turnout. And what was interesting at SRS, you had a pretty sprawling booth. And of course, what we'll always do is put a system in there to take up the booth. But then in New York City, we had a relatively small room, about the size of an ASC.
Yeah.
System fit comfortably in there as well, with about 20 people in there as you demoed it.
Yeah, and I think that obviously the smaller room, is I'm pretty sure the real estate in Orlando is, a little bit cheaper than New York City. But, rough approximate, size of our normal operating rooms that we suggest would approximately be about 400 square feet, so that you could fit everything in, in addition to like anesthesia and then all your ancillary equipment.
Yeah. Well, tell me about SS Innovation and starting out with the foothold in India and where large format soft tissue surgical robotics volume sits right now.
So our origin story actually emerged from my father, Dr. Sudhir Srivastava. So he's one of the early pioneers in robotic cardiac surgery. As you know, the Da Vinci robot initially, with Dr. Fred Moll, they started on the heart. And I guess the logic was that if you could do, coronary bypass surgery, then everything else would be possible to do. He accumulated a huge volume in the US. Simultaneously, he was doing a lot of charity work and launching programs globally, particularly in India, because that's his origin story. And what he found was is that although he was pushing the envelope and this spectacular technology, due to the prohibitive nature of the cost, to benefit from it, he always raised this question, that I have this, wonderful technology. I've developed this amazing skill set where his cardiac bypass patients or even valve patients would go home in like 1 to 2 days. Because as with all surgical subspecialties, they all have endoscopic options, with all due respect. But in the thorax being a small space, I know in thoracic surgery, they have VATs and cardiac. Still today, 95 to 98% are doing, median sternotomy, which is highly invasive and really affects the quality of life and outcomes for the patients. So he wanted to figure out a way, because no one else was going to do it. So he really wanted to figure out a way to do it himself. And then that's, one of those back to the drawing board moments. And that's sort of where the journey started in India, I think about 14, 15 years ago.
Yeah. And the install base currently on robotics, you were sharing with me when we were in New York, that SS Innovations platform has had a pretty aggressive uptake and utilization in India right now.
Yeah, I think part of that reason was so, we went through the same learning curve as most other people, as you can imagine, first, in 2012, 13 timeline. Once he decided, that he wanted to pursue, sort of stepping away as being a clinician and focusing on surgical robotic development, it's not like a turnkey, situation. You have to go back, you have to learn the core fundamentals of surgical robotics, and with that comes engineering and it is very humbling, actually. I have to say, considering for a cardiac surgeon, right? And they're kind of gods in their realm to be able to go back and then go back to the drawing board and become a student again. But what that translated was is, see, he was already an end user. He knew what he needed at the highest level of surgery. But then how to understand the core principles of mechatronics and surgical robotics, in order to develop a system that will work. But rapidly they developed. He started a small team initially once he did his basic learning in Germany and at DLR, which is the German aerospace division. Then he came back to India, put a small team of engineers together, and then as fundraising, as like you raise enough funds to get you to the next milestone, and to 6 years later, then we kind of grew from a team of 5 to a team of 60. And where we are today is about a team of 300. And we were able to scale up pretty rapidly. I think India, just the level of talent that's, accessible. And, keep in mind that, our greatest, sort of rapid flow of development, occurred during the pandemic. So then, of course, we got stuck with supply chain issues. So that did hamper us. It wasn't ideal as per our temperament. But I think that, where we are today, once we deployed one system, then of course, being the new kids on the block, a lot of people just wanted to sit back and watch and wait. But then when we started showing that our system could be utilized not only for simple procedures, where I think a lot of other companies get stuck, that we were doing radical prostatectomies and very complex general surgery procedures, cardiac, of course, we were able to perform successfully. And I think that, once you address the affordability factor, and that was always the problem in countries like India and other parts of the world. And if you can produce equal or better clinical outcomes at a much lower cost, then really it's a no-brainer, I think, moving forward. And we really want to provide affordability and accessibility to parts of what I call the forgotten world, right? That where larger companies, it's not really a priority for them, to establish their footprint in those parts.
And to date, there's about 220 robotic systems in India, but a reasonable percentage, based on the timeline that Mantra's been on market, has taken up a pretty good number in relation to that. Share that on that.
Yeah, so that's a really interesting, numerical, like I guess, factoid, because robotic surgery was initially approved in 2002. I remember my father, he did the first robotic cardiac surgery, which was the first robotic surgical procedure in India in 2002. So since then, now here we are, 22 years later, and there's only total of 220 systems. It's worth pointing out that of those 220 systems, we've been able to place 50 in less than 2 years. So we're, approximately close to like 37, 39% of the market share. And I think a lot of that has to do with our affordability factor and considering the fact that we didn't compromise any quality. And I think a lot of that has to do when, your boss is a cardiac surgeon.
You had mentioned that we were a team of 3 to 60, and then 60 to 300 now. But one of the observations I've had about SSI is, while most surgical robotic companies are a single platform, and great single platforms, SS Innovations in India, you moved from Mantra 2, and tell the story, Mantra 2, where you did a majority of your cases, to Mantra 3, in my opinion, an insane level of speed and excellence. And you can only do that if you're a digital surgery company at large. So take us on that evolution from 2 to 3.
So I think, even going from Mantra 1 to 2. So Mantra 1 was a sort of a modular serial manipulator system. It looked very similar to like a very sleek industrial arm. We did a clinical trial in December of 2020 at Rajiv Gandhi Cancer Institute, which is pretty much like the MD Anderson of India, where, it's like highly complex, surgical procedures only within the realm of cancer. The team, Dr. Sudhir Rawal, so he's one of the most famous robotic uro-oncology surgeons in the country. I think he's done like 4,000 or 5,000 cases by now on Da Vinci and our platform. So they were able to utilize that system I think they did 18 surgeries in 14 patients in that initial clinical trial. I remember the first case, they did robotic cholecystectomy and hysterectomy through the same ports. So that was actually very interesting. And then after that, normally in a clinical trial, you want to do like your bread and butter cases. Unfortunately, or fortunately, I guess depends how you look at it. For us in a cancer surgical hospital, there are no simple cases. So this was really, when you're talking about, letting the tires hit the road, was a huge validation. But what we found out was that, they're an excellent team. So you could give them anything and they'll make it work. our goal initially and still today was to cater to, the entire spectrum of surgical teams, from novices to, expert surgeons and everything in between, to make it available, to most programs. So then we decided in January of 21 that we had to do something different. That's when we came up with Mantra 2. That development took about 6 months. I think part of the reason during that time, while we were able to evolve very rapidly, is because we were qualified as essential workers due to being medical device during the pandemic. So there was no traffic in a city of New Delhi with 30 million people. We were able to work, and get the job done. I think also part of the reason was we had the leadership of end users, all being, robotic surgeons who figured out, what they need, what's required, and how we can improve. And then we had this rock star team of engineers who, they worked weekends, holidays. I mean, they didn't care. Like, they only had one goal of being able to develop the system. Once we were able to develop Mantra 2, we did another clinical trial, like hysterectomy, prostatectomy, nephrectomies, again, mostly urology, oncology, and gynecology. And then the first system sale occurred of Mantra 2 in July, August of 2022. And then basically, then they started doing all, the entire spectrum of procedures. I'm not going to say that there weren't any technology challenges and hiccups in the beginning. You have to debug a lot of things, and everything always works perfectly in the lab. But we were able to work closely with our clinical teams and, experts in the field and from various institutions. And due to their feedback, we were really able to very rapidly refine our platform. And with our Mantra 2 system, until we transitioned to Mantra 3, we were able to do more than 1,800 clinical procedures, from, transoral in the mouth all the way down to the pelvis and everything in between, including cardiac. Mantra 3 occurred so the catalyst that sparked that was we were beginning to get pretty intrigued and, curious about telesurgery. So in January of 24, Dr. Sudhir, our chairman and CEO, made the decision that I want to make something, very radical, very different, incorporating our active hand controls, that normal gimbal mechanism, but also have a provision to utilize a different technology, a different way of approaching, how the surgeon computer interface works in order to execute telesurgery. So within 5 months, again, and trust me, those 5 months are not easy, like for any of us, but we set a goal, we did it. And I think part of the reason why is, we're kind of emerging out of our startup phase, and I don't know, I mean, everyone has a different measure of, when they come out of startup into a full-fledged and functioning business. But when you're poor, you have to work fast, right? And every dollar counts. When every time you have a new project and you have allocation of resources, recruitment of human resources in order to achieve that goal. So we came up with Mantra 3 very quickly. We showcased it in June, on June 13th of this year. And then shortly thereafter, we are in SRS and, gathering just feedback from people, prior to its clinical use. And since its clinical use has been, executed in India, now we've used up to 5 arms in single procedures from a single surgeon console. Our newer technological platforms allows for 2 consoles to be used utilizing all 5 arms. So it's not like, you have to switch back and forth between consoles. Like, you can have a primary surgeon and secondary surgeon controlling all 5 arms. And then, of course, telesurgery, which we were able to successfully do in the country.
Yeah, I think you shared the story about Sudhir proctoring a telesurgery while he was having lunch. He had was that right? Is that the lore of that?
Yeah, he was actually teleproctoring. So he was sitting in our office in New Delhi, Gurgaon. So Delhi, Gurgaon is called NCR, which is very similar to like Washington, D.C., or it borders with like several states. And he was sitting there and he was proctoring. They were doing an ASD repair, so atrial septal defect, 2,000 kilometers away. And he was having lunch and he had this these augmented reality glasses on and just talk them through it. And maybe, we can discuss later our whole sort of philosophy of, training and teleproctoring and ultimately what we feel telesurgery from our own philosophy should be.
Mm.
But yeah, he was able to do it. He was having his lunch and calmly talking these guys through, intracardiac procedure.
That's a cardiac surgeon, old school gangster for me. One
Oh,
of the
trust
thing,
me.
what's that?
I said, trust me, I know. Imagine being his kid.
No pressure. No pressure. One of the things that's really interesting is the robust instrumentation set, both on the surgical side as well as the cardiac side. And I believe we've got over 40 multi-specialty instruments, and maybe just as many, I think 20 or half that on the cardiac specialty side. That in itself is a massive undertaking, yet you've accumulated this pretty substantial portfolio. Take us through that a little bit.
So I think, part of the reason why, we are able to accumulate such a large portfolio when it comes to instrumentation is that you see till date, I think that we've come into the surgical robotic space at a very mature stage because surgical robotics has been around for decades now, right? Uh, and because of that, see when we're training as surgeons, like every surgical subspecialty, they have their own quiver of instruments, that are required to get the job done. So when you're coming up with a new surgical robotic platform, ultimately you have to deliver if you want it to be successful and adoptable, by surgeons, even in a country like India or globally, in the big picture. But see, you have to have the instrumentation in order um, to allow the surgeons to be able to do what they want to do unhinged and unhindered, right? So gynae, they'll have their own particular instrumentation, urology, general surgery. Of course, there's a lot of overlap between common instruments, within surgical subspecialties. But until and unless you have those instruments, see, without the tools, it's really hard to have the talent, right? And that especially is, a big thing in surgery because see, the last thing that you want to impose on a surgeon is, limits of what they need to do to execute, the procedure. And so that, our rapid development. So a lot of it, the hardest part I think was finding people, partners, like vendors, to be able to produce, at a micro level, very sophisticated instrumentation. Luckily, we were able to do it, although it did take, there's a lot of trial and error that went into it. Our instrumentation right now supports all surgical subspecialties, minus neuro and ortho, but all soft tissue, and then including cardiac. Now, part of the reason why, we were able to excel in cardiac was, because of the leadership of my father, being a robotic cardiac surgeon. He knew what was required. Currently, there's a huge dearth of instrumentation, in that specialty. And he really wanted to be able to revive the field, obviously due to the benefit, that patients receive from such approaches. But we have everything from both coronary revascularization, stabilizer, intracardiac instruments, so blade retractors, all the proper forceps. We've also been working very closely with various third-party companies when it comes to like trying to make interrupted anastomotic sutures, because running sutures and then can become challenging, depending on skill level from surgeon to surgeon. And then we've also developed this coronary anastomotic connector, which we're calling Nadi. And Nadi basically means like a river in Sanskrit. So basically, to establish that bypass to allow for flow to occur. And that's basically a micro stapling device, which will fire, you can join, two arteries in 6 seconds and creates like an end-to-side anastomosis. And that's something that that's kind of what we call our crown jewel right now, because beyond cardiac surgical application, because we're starting small with coronary vessels, there's a huge application in other specialties when it comes to like renal transplant, hepatobiliary, AV fistula formation, or any type of anastomosis. So once we've successfully performed our clinical trial on that, our goal is to go back to the drawing board and design them from other surgical subspecialties to be able to facilitate and enable surgeons to be able to work very expeditiously in such procedures.
Yeah, and again, an example of a company that's more than just a single platform, that Nadi technology base, in most cases, would be a startup medical device company in itself. So, I really like the brain power that we've got there. And then you had mentioned the ongoing training and the other technologies that we're working on, the SS Maya, and we talk about enhancing surgical capabilities. That's another suite of experiences and products coming out of SSI.
Yeah, so our Maya team was actually developed. So starting back in like 2019, we were very fortunate enough to hire an engineering at that time postgraduate. He did his PG in Canada in Toronto, and we hired him initially as a technical writer, and discovered very quickly that he was very talented in the whole AI, augmented reality, VR, XR space. So he kind of basically, uh, I don't know how Maya emerged, but he came up to us with a design and this program where he could immediately convert any DICOM image based on the software algorithm he wrote, so CT, MRI, PET scan, into through his software into a workable 3D model, where you could rotate, slice, dice. So it was like a DICOM viewer, but it was sort of a DICOM viewer on steroids, if you can, put it that way. And then from that, we thought that there's a huge application for this when it comes to surgical planning. See, because as surgeons, we piddle around because we don't want to injure vessels or nerve bundles and branches. So if you see the anatomy right in front of you, in a live operative setting, then it gives you sort of that, it serves as a guide to be able to let like where to cut, or if you're going too deep, etc. Then from Maya emerged this whole other platform, sort of the evolution of our Maya. And just so you know, like Maya in Sanskrit, I know it's a word that's commonly used, but it means illusion. So it's like there, but it's not there, right? And we thought that was very appropriate from this, sort of virtual space and application. But then being able to utilize it for a training methodology, training protocol. And one thing, and we did investigate into this whole simulation aspect of, because everyone else is using it. They use these backpacks from, third-party companies that they put onto their consoles and systems. And, we checked it out. But we wanted to take our time and do things a little bit different. And part of the goal with that was, since now we had the capability of being able to convert CT, MRI, whatever digital inputs, into a workable 3D model, then what the next step in our minds was to be able to create a patient-specific simulation so that, you have the anatomy. So there might be a, aberrant or accessory renal artery, or cardiac anatomy might be different, or, et cetera, to be able to incorporate that, into a simulation platform so that we could perform the surgery on the patient before actually performing the surgery. I think a really good example of this would be like a mitral valve repair or replacement. Normally, in surgery during those procedures, you have to bring like the annular rings in to like measure and everything. So now if you could do that ahead of time, you're saving a lot of time, cutting down on anesthesia, and ultimately who benefits is the patient, right? So we want to be able to, and I think when I said previously that we're really coming into this space, at a very mature stage, because see, a lot of technology is available today, which wasn't even imaginable or possible, 20 years ago. So how to utilize the latest technologies, and see, it's all exploding around us. So how to, harness that, incorporate that, and use that in our platform, whether it be off-the-shelf technology or collaborating with people, but to be able to create a surgical robotic platform from an operations, clinical use, training point of view, so that it can be utilized and make it affordable and accessible. I think this has been sort of the challenge that we've undertaken. And I think, where we are today, it's a testament to the fact that it's working somehow. I'm sorry, there are fireworks going on right now.
It's okay. They're celebrating for you. Take it,
So,
take it and run.
yeah.
So I got a question for you.
Okay.
We've talked about cost, value, obviously to to the user, to the hospital, and obviously to the patient. Just without giving specific numbers, what's the multiple between potentially a Da Vinci 5 all wrapped in with maintenance and service to the Mantra 3 as we project it roughly to be? Is it a third? Is it half? Is it three quarters? Just roughly, just so I can spitball it.
Yeah, I'd say we're approximately a third, and we're a third without the consideration of customs duty into a country like India, right? So immediately in India, you have a 30% customs. So whatever the selling price is with for the DV5 in the US, by the time it comes to India, like it's exponentially more unaffordable, I think. And by the time that they roll it out, although they've had great success in the US, right? See, in the US, it's a totally different ball game because you have insurance reimbursements, it's supported by the hospitals. You also have the spending power. Whereas in a country like India, insurance for reimbursements with robotic surgery, we're still learning a little bit about it. So it's not fully accepted wholly. Um, the running costs were at approximately a third our per procedure. See, our biggest goal was to be able to offer our solution at per procedure cost of within 10 to 15% of laparoscopy charges,
Wow.
right? See, and when I look at it sort of, from a big picture, see, I think competition is a great thing. I think it allows all of us to stay on our toes and really, it pushes the envelope for everyone. I think Da Vinci is a perfect example of that. I think we are, there's a handful of other companies, but there's a market share for everyone, and I think that's okay. My biggest competitor are laparoscopic towers. All right. So as you see when we train in surgery, we start open, and then there's the evolution to lap surgery, and then from lap to surgical robotics. And there's been a need of the hour for every generational step that occurred. As you well know, in robotic surgery, it allows you to do a lot of very complex procedures more comfortably, which are very challenging, to perform laparoscopically. So if I can convert one laparoscopic tower to one of my systems, if it's very close and running costs, right, beyond the capital investment of the hospital, then I think I'm doing a very good thing, because simple procedures can still be done very comfortably, and then you have the added benefit of doing very complex procedures. And I think that you rightly pointed out earlier the whole ASC consideration moving forward of smaller ambulatory, surgical centers, being able to have access where then now you don't have to refer them to large university hospitals, huge socioeconomic, implications of patients now having to travel, take time off of work, and not only the patients, but their families. So see, the ultimate goal of technology, and this is how we look at it very holistically, that see, technology is only good, if it serves most, right? And if only an elite few have access, then you're kind of you're cornering yourself in, to be able to offer this amazing technology, but not many people can benefit. So I think our mantra, right, as a company, was to be able to take the latest technologies and make them available, accessible, and affordable to all people. Because where we are today and how quickly we've evolved as a society and technologically, and evolutions of science and medicine, there's if the only reason why things are not affordable and accessible and not being utilized globally, if the only prohibitive factor is the cost, then that's not a good enough reason for me moving forward. Because as we're progressing forward, as you well know, as technology progresses and advances, it becomes more affordable. It's like when cell phones first came out, right? I had this huge Qualcomm that cost $2,000, that I carry around in a bag, right? And now in India, every rickshaw driver has a cell phone, every cab driver has a cell phone, vegetable sellers, they have cell phones. And because of that, cell phones, also with emerging, peripheral technologies like, Google Pay and stuff like that, now everybody has a bank account, right?
Mm,
So, this is sort of where it's headed. And, either you get on board or I feel that you'll get left behind.
agreed. So as we wrap up, you had some great highlights the last, let's just go back 18 months or so, between number of installs, number of surgeons, number of teams, members trained, procedures. Summarize for us, if you can, the highlights that really stick out to you and the team there.
Yeah, so in the last 18 months, we've sold about 50 systems. And now I will be honest with you, in the beginning, it was a little bit, like, yeah, obviously the curve wasn't very steep because a lot of people wanted to watch and wait and see how the system performs, and rightly so. Once I think people were able to see that it was performing, then we saw an exponential increase, especially after our January 2024 event, where we did our first global conference, highlighting the Munther system. At that time, it was Munther 2. We did 14 live cases over 2 days. And the reason why, the slide here, I see 40 plus live surgical demonstration, it's coincides with Murphy's Law. There's any time anything usually does go wrong is during such, demonstrations. All of them have been flawless. We've had no incidences. Now, currently today, we've done more than 1,900 surgeries, 80 different types of surgical procedures. So from transoral down to the pelvis and everything in between, including cardiac. And, due to, the number. So if you look at 50 systems sold, assuming that there's approximately 10 surgeons, in every program, more than 500 surgeons trained. And then with operating room support staff and nurses, more than 1,000 people, have been trained in a very short time. Our training methodology is very holistic. We focus on, like, when I show up or my team shows up at a hospital, I divide everyone into three. So I got surgeons and assistant surgeons, then nurses, and then support staff. And we take them through a very rigorous, training regimen where we spend a lot of time on didactic modules, hands-on training, dry runs. And then ultimately, before they do their first case, then we organize physical proctors. Our goal with teleproctoring and telesurgery. So for teleproctoring, it's very inefficient in today's day and age for surgeons, to keep flying here and there, because now they got to take 1, 2 days off of their own busy practice, go out. They have no idea about the skill level of the surgeons or, the complexity of that procedure. So through teleproctoring, it's like having an attending in the room, right? So because ultimately the goal of a proctor is to guide the student doctor, and should that now trainee encounter a very difficult situation, say for example, doing like a UV anastomosis and a prostatectomy, or doing the cardiac anastomosis, and Lima to LAD bypass, then the expert surgeon can take over, telesurgically, and get them through that next step. So it's very similar to how we always trained, where the attendings there, their goal is to teach you and bring you to maturity as a surgeon. But you always have someone looking over your shoulder, and, someone's got your back so that they can take over if needed. And I think what that does, it instills the safety and confidence, in the learning surgeon, the surgeon who's being proctored and guided. Because see, ultimately, at the end of the day, patient safety is paramount. And our idea of telesurgery is not to have like one rock star surgeon operating in, he's not omnipresent, operating in 100 places in the world. Our goal is to be able to create and launch self-sustainable programs, because see, at the end of the day, I think a lot of this has to do with our core ethos, given that we're a robotic company that started and run by doctors, is that until and unless the surgical program succeeds, I will not feel like I've succeeded, right? As a teacher, as a mentor, and I have a huge responsibility in order to, achieve that.
It's interesting you said something there that very few organizations have a chance to say is the core ethos. This is a company that was started by and grown by docs, and you're a digital forward first company, where most of the other medical device companies, other than Intuitive for the most part, at the scale right now that SSI is at, are an analog med tech company trying to move to digital. And that is a challenging shift in mindset, technology, and also what you have to burn away in order to become digital. So I think it's put SSI in a very, very, I think, interesting and advantageous place. And then one other item before we go. I think it's important to point out all these procedures you've done, all these surgeons trained. If I remember correctly, not a single adverse event on the system or with the surgeon at this point in time. Is that
Yeah.
accurate?
Yeah, that's totally accurate. So in now more than 1,900 procedures, We've had zero mortalities, zero device-related injuries, zero device-related complications. We have had, protective faults and quick stops and things like that in order to protect the patient. But then, of course, you just clear the fault and then you carry on. But yeah, so I think this is a huge validation of sort of, the level of scrutiny that we impose not only on ourselves, but on our engineers when we're developing the system. We always tell them, right? Develop the system in such a way, work in such a way so that you would feel comfortable that, our system, the system that you've helped to create, can operate on your mother, your father, your brother, your sister, really take that into consideration, for every minute that you spend, and the work that you do. And I think, part of that and that sincerity that, that uh, exists, amongst our team is what has allowed us to achieve where we are today in a very short time.
Yeah. Well, I'll tell you what, I love the technology. I love the humility that the organization brings, and I love the way it's really pushing the boundaries. And I truly appreciate your time. I know you're busy there in Bali with an event right now and some exciting news coming up shortly, I understand as well. So always appreciate our conversations.
Thank you, Joe. I really appreciate your time and the opportunity.
You
Thank you.
got it. I'm Joe Mullings from 160 Studios. Be well.